Welcome back, dear listeners, to another episode of Med Madness, where we unravel the complexities of medicine, one topic at a time. Today we're diving deep into a condition that affects millions worldwide, but often remains shrouded in mystery: endometriosis. We'll explore its pathophysiology, clinical manifestations, differential diagnoses, and management. So grab your stethoscopes and let's get started. First off, what is endometriosis? At its core, endometriosis is the presence of endometrial tissue. Yes, the same lining that sheds during menstruation, but located outside the uterus. These ectopic implants are typically found within the abdominopelvic cavity. Now you might wonder, how does this rogue tissue end up where it shouldn't be? The pathophysiology isn't entirely nailed down, but two leading theories prevail: cellular metaplasia. This is where peritoneal cells, those lining the abdominal cavity, transform into endometrial-like cells. Retrograde menstruation. Imagine menstrual blood taking a detour, flowing backward through the fallopian tubes into the pelvic cavity. This blood carries endometrial cells that implant and grow in their new homes. Once settled, these ectopic implants behave just like their uterine counterparts. They proliferate and shed with each menstrual cycle. But instead of a straightforward exit, they cause intra-abdominal inflammation, fibrosis, and, you guessed it, pain. But with symptoms overlapping various conditions, how do we differentiate? Great question. Several conditions can mimic endometriosis, and it's crucial to distinguish them. Epithelial ovarian carcinoma presents with an ovarian mass and pelvic pain. Ultrasound reveals a septate mass with both solid and cystic components. Mature teratomas, also known as dermoid cysts, might cause pelvic pain or pressure, but don't typically impact fertility. On ultrasound, they showcase calcifications and hyperechoic nodules. Pedunculated leiomyomas, commonly known as fibroids, arise from the uterus, not the ovaries, and cause pelvic pressure due to mass effect. Pelvic congestion syndrome mainly affects fertile women during or post-pregnancy. It leads to pelvic pain associated with intercourse, with ultrasound showing visible venous dilation, not a unilocular hypoechoic mass. Tubovarian abscess is a complication of pelvic inflammatory disease, presenting with pelvic pain and an ovarian mass. Ultrasound depicts a complex, multicystic adnexal mass with enhancing rims. Understanding these nuances aids in accurate diagnosis and management. To bring this discussion to life, let's consider a real-world scenario. A 28-year-old avid runner has noticed escalating pelvic pain over the past year, especially during workouts and intimate moments. Recently, she's been trying to conceive without success. Concerned, she visits her gynecologist. An ultrasound reveals a unilocular adnexal mass with homogeneous, low-level echoes on her left ovary. Given her symptoms and imaging findings, she is diagnosed with an endometrioma resulting from endometriosis. After discussing options, she opts for surgical resection. Post-surgery, not only does her pain subside, but within a year she's expecting her first child. This story underscores the importance of recognizing and addressing endometriosis promptly. So what do we do when faced with symptomatic endometriomas? Surgical resection, such as a cystectomy, is often the path forward. This approach aims to alleviate pain, enhance fertility prospects, and reduce the risk of ovarian torsion. Early and effective intervention can make a world of difference. To wrap up, endometriosis is a pervasive condition causing pelvic pain, dyspareunia, and infertility due to ectopic endometrial implants. Recognizing its manifestations and differentiating it from similar conditions is pivotal for effective management. Before we sign off, I encourage all our listeners to engage with our pre- and post-podcast quizzes and dive into the Anki flashcards we've prepared. They're tailored to reinforce today's insights and ensure you're exam ready. Thank you for tuning into Med Madness. Stay curious, stay informed, and until next time, keep the madness alive.